and welcome to a Health Podyssey. I'm your host, Alan Weil. The development of highly effective vaccines dramatically changed the course of the COVID-19 pandemic. But once vaccines were broadly available, a key challenge was making sure people became vaccinated. While some were eager to get the potentially life-saving shots, others were more hesitant. Now, in order to encourage uptake, a handful of states provided financial incentives for getting vaccinated. Some employed highly publicized lotteries, doling out large sums to a few lucky winners, while others offered smaller amounts to broad categories of people who got vaccinated. West Virginia took the latter approach, providing valuable cash benefits to young adults who became fully vaccinated against COVID-19. So, did this approach work? That's the topic of today's episode of A Health Podyssey. I'm here with Charles Stoecker, Associate Professor at the Tulane School of Public Health and Tropical Medicine. Dr. Stoecker and co-authors published a paper in the May 2024 issue of Health Affairs examining the effects of West Virginia's COVID-19 vaccine incentive payment program. They did find the program to be effective, findings that we'll discuss in more detail in today's episode. Dr. Stoecker, welcome to the program.
Good to be here.
So it's probably good if we just sort of start with, what did West Virginia do? What was the program that they put in place designed to increase uptake of the COVID-19 vaccine?
Of course, West Virginia did a lot of things, but what we're focusing on right now is a $100 cash incentive. So if you got vaccinated before the deadline and you were below age 35 or below, above age 16, then they would give you $100. Now, West Virginia did later implement a lottery, but that's outside of the scope of this paper. So somewhat interestingly, when the governor was announcing this, they named it the Beat 558 BAD program, which is a very unusual name. And so the provenance of this is that the governor had received some statistics that 40% of vaccine-eligible West Virginians did not intend to get the vaccine. And that worked out to be about 588,000 of them. And so he proclaimed in his usual colorful style, we got to beat 558 bad.
Well, I wouldn't have known that phrase if I hadn't read it in your paper, but I appreciate getting the backstory there. So this is in the context of what I guess we would say is high levels of vaccine hesitancy. There were folks just saying this isn't for them. Is there anything else you could say about sort of the overall experience of how the pandemic rolled out in West Virginia, just to give us the context here?
Well, we all lived through it. We may try our hardest to forget, but when the COVID disease comes along, a lot of people die. We have very little tools in our kit to prevent its spread or to treat infections, at least initially. So at the time that this incentive had rolled out in West Virginia, 2,800 people have died. Since then, many, many more, but already that's the size of a small town in that state. If you recall, vaccines were initially quite scarce. They were rationed. Only certain people could get them. And then you had an appointment, and at least I was very excited to get my appointment and finally go. And you do feel some sense of relief as you're now vaccinated, and you feel that you can start going back to your normal life. So after that initial set of people that really wanted the vaccines, the rate of vaccination slowed down. So that's kind of the context that we're looking at it for this particular policy change. Now, the feds had provided each state with quite a sizable chunk of money that they could spend as they wished to combat the pandemic. The states spent that in a lot of different ways. As you mentioned in the introduction, some states, they could dedicate it to incentives for, say, lotteries. Some states put it toward incentives for testing. And then there were 3 states that put it toward statewide incentives for guaranteed cash incentives for the vaccine. So those were California, which gave $50, Louisiana, which gave $100, and then West Virginia, which we're talking about today, which also gave $100.
You know, money talks and dollars catch people's attention. I'll turn back to the lottery experience later on. But when the governor said this and said, we're going to do this program, was there a reason to think it would be successful? Did we have a literature saying people will get vaccinated if you pay them?
So I think that, this is the first pandemic we've been through in a long time. So I don't think that we necessarily had models of these population-wide vaccine incentive programs. And so the beauty and the curse of the United States is that each state is its own laboratory. So every state does some tinkering, and kind of after the dust has settled a little bit, we're going back and raking through what happened and trying to figure out which approach was best, or the pros and cons of each approach.
It's a bit of a gamble, but it's a time when everyone was trying to figure out what would work. And as you note, there were some federal dollars available. And so this is the approach that West Virginia takes. Well, let's jump to what you found. You looked at the question of whether or not these incentives actually led to an increase in vaccinations. What's the answer?
The answer is 12%. So we can detect an effect of about a 12 percentage point impact over a baseline of 28%. So going through the history of West Virginia, it was actually one of the states that had initially quite high vaccine uptake rate back during when the vaccine was scarce. They seemed to be a little bit ahead of the curve in getting the shots into people's arms, as the phrase went. By the time that this incentive is announced, West Virginia has fallen behind a lot of the states, and I think right now it's kind of toward the bottom of the set of states that have COVID vaccine uptake. So 12 percentage points. This is responsible for about 20% of the total vaccines in young adults by the end of the program. At the end of the program, the vaccine rate among young adults is about 60%, and 12% of that boost we can causally assign to this program. So that 12%, it breaks down to two parts. The incentive was targeted at the under 35s because they had lower vaccine rates initially and higher hesitancy. So they were about 3 percentage points behind older adults at the start, and they were about 9 percentage points ahead after the program had finished.
So, of course, we're not a methods podcast, but I think it might help our audience to understand, how did you approach figuring out the effects of West Virginia's program?
The reason we're studying West Virginia and not the other states that had guaranteed cash incentives is that those incentives were available to everyone statewide in California and Louisiana. West Virginia's was restricted to people under age 35, and then only during a certain time period. So we have two differences to exploit. And so what we're going to do is we're going to compare the people who are 36 and above to the people that are 35 and below. In fact, we do some things where we compare just the 35-year-olds to the 36-year-olds, essentially. And we're going to compare those young adult to older adult gaps before and after the program to see what kind of effects the program had. Now, no empirical study is complete without some robustness tests. So we look at a few things. One is we look at another outcome. So in the survey that we're using, they ask both, did you get a COVID vaccine? And also, did you complete your series, or do you intend to complete your series? Now, that second question, it's not ideal. I wish they'd just ask, did you complete your series? But we find similar results across two questions. And then we do a couple of placebo tests. So placebo is where you expect to not find an impact. We look at other age cutoffs. So in West Virginia, they made it available to people 35 and below. So let's look and see if we find an impact at 36 below, 37 below, or 34 or 33. So we look at all the ages between 30 and 50, and we find no other statistically significant positive impacts across either of our two outcomes. And then the last placebo test we do is we look at other states. So we find this impact at age 35 in West Virginia. Well, let's look at California. Let's look at Louisiana. All of the other 49 states plus DC, we find no other positive statistically significant impacts. So this is why you should hopefully believe the results that we found.
I'm glad earlier on in the conversation you reminded us that at the beginning there was scarcity, and then there was availability. And so one of the challenges, I think, from a public health perspective was that at the beginning we were sort of saying, not you yet. And then it's like, okay, we want you now. And if I remember right, you talked about the wonders of different states taking different approaches. There were also like different priorities given to different people in different locations. Again, we have all blocked a little bit of this out in our memory. But is your sense, because you said that West Virginia started out with relatively high rates, so is your sense that sort of the targeted elements at the early stages were more effective or reached more people, but then the sort of wait in line just led people to maybe think it was never going to be their turn? I'm just trying to understand sort of the temporal dynamics here.
It's complex, and I want to say that we don't have a good way to unpack this causally, but we can think about the different attributes that would go into this. Some of the attributes are like how you deliver the vaccine. So West Virginia was successful very early on in like harnessing some local partners to make the vaccine available on the ground. And then the other part is how people view taking that vaccine. And so while West Virginia may have been successful at harnessing local partners, the population in West Virginia may have been more hesitant. And so they may have been quick to reach their floor, but their ceiling may have been lower than in other states.
Right. So I appreciate that the data behind this there's a certain amount of speculation involved, but that's very useful to think of this as both sort of floor and ceiling, that there's a range in here. And the question is, how do you get closer to the ceiling when that time comes? Well, I want to talk to you a little bit more about how the program effects played out and then sort of what implications that has for the future. We'll cover those topics after we take a short break. And we're back. I'm speaking with Dr. Charles Stoecker about a guaranteed cash incentive program in West Virginia. Before the break, we learned that you can directly attribute a 12% increase in vaccine rates to these cash incentives. So that's a pretty amazing story. And as you said before the break, it's not just the percent, it counts for a very large share of people who actually got vaccinated, which I would say, as we're looking for policies that have effects, this looks pretty dramatic. Before we go into sort of the implications, I am curious. This was an age-restricted incentive. And if you could just say anything about, to go deeper than that 12%. Who did it bring in? What do we know about them? Are those that it was not ineffective in bringing in? What more detail could you provide?
It's probably not surprising to know that the $100 cash incentive seems to have appealed more to people on the lower end of the income distribution. So we find that most of the program impacts are concentrated in people who made less than $35,000 per year or who were unemployed at the time. In fact, we find very little detectable impacts on people over those income thresholds. The second thing that we can say is that it appears that your experience with infection seems to have changed how easily the lottery influenced you. So it was people that hadn't had prior COVID infections that seemed to respond to the lottery most. And that might make sense if you think that you're protected by some natural immunity, you're less likely to respond to the $100.
Yes, I thought that was a particularly interesting finding. And actually, I hadn't thought of it so much as about having a natural immunity as I was thinking sort of about what changes your view about the importance of the vaccine. And that in the absence of personal experience, you might say, well, I'm not that worried, but I'll take $100. But once you've had the personal experience, it's not about the money, it's about your health. So I guess I had a slightly different interpretation. But of course, again, you're just measuring the aggregate data here.
We can always wish for better data. And it would be great to have a question that separated, did you have a severe COVID illness from did you have a mild COVID illness? And I can imagine a mild COVID illness might lead you to not get vaccinated, but a severe one might lead you to get vaccinated. So, but we need to go back in time and administer a different survey.
Right. Let's go back in time and do a different survey and not have another pandemic to study this. That's certainly not worth it. So, economists talk about moral hazard, and I couldn't help but wonder as I read this about the concern that if people think, I'm not going to get the vaccine now because if the rates are low, they'll come along and give us a financial incentive for doing it. You know what I mean? Sort of I'm going to hold out until they pay me for it. Is that something that folks talk about, or is that just sort of an economist's query?
Moral hazard is behavior change when you're insured. So there's no real insurance going on here. But this idea that people might delay their vaccines to qualify for the incentive doesn't apply. The way that I've seen most of these reward schemes structured is, if you have been vaccinated. So if you showed receipt of the vaccine, regardless of whether it had been before or after the program announcement, you would still qualify for the $100. So hopefully there's no unintended consequences. These seem to have generally been thought through carefully, certainly in the West Virginia case.
So let me ask about the lottery structure, because that's something you alluded to earlier, and you said they actually adopted one later. What can you tell me about what we know about the lottery approach as opposed to the guaranteed cash for everyone who gets the vaccine?
So to borrow a phrase you used earlier, it's a gamble. right? So the lottery idea is that we can kind of exploit this interesting quirk of how humans think about numbers. And the idea is that from behavioral economics is that we tend to overstate small probabilities. So if I tell you that you have a 1 in 1 million chance of winning a lottery, your response, I mean, you were evolved in caveman times and you didn't really have to deal with probabilities as small as 1 out of a million. So your response is, well, there's a chance. And so if you think, you have a 1 out of 1 million chance of winning a lottery jackpot worth $1 million, the expected value, the average payout that you'd expect to see is $1. It's quite small. And so the idea behind these lottery incentives is we can get more bang for our buck. We can put out these $1 million jackpots, and several states had $1 million jackpots. And that $1 million cost is going to be relatively modest compared to paying everyone $100. And so the idea is that the lotteries may be more efficient.
And are they?
Well, it depends on exactly what you mean by efficiency. So kind of sorting through the literature on the lotteries, we have an earlier study that looked at the Louisiana lottery, which gave out a few $1 million cash prizes. And we find that boosted vaccination rates in Louisiana by 1.37%. So quite a bit lower than the 12% we're finding for the West Virginia cash incentive program. There have been some other studies that look at Ohio's lottery, maybe a fraction of a percent, maybe on average, the range. A couple of different studies have looked at I think it's the 12 states that have these lotteries, somewhere to a very small but detectable impact up to maybe 2%. So all of these are quite a bit lower, maybe an order of magnitude lower than what we find in the incentive pool. So what could be going on here? There's a few things. One is that in West Virginia, the incentive applied to people below 35, these people could be, hey, this program is for me. By focusing on a particular group, those people may feel more singled out and more special. I already mentioned the low expected value of the lotteries. Even though they had large cash payouts, it's possible that people are able to do the math. With the behavioral economics idea is that maybe you'll make an error on the math, but it doesn't say how big the error is. So maybe you overstate your probability of 1 out of a million chance, but maybe you round it up to 1 out of 500,000, and it's still quite a low payout in the end. And then, so there have been some studies that looked at the West Virginia lottery specifically that happened after the West Virginia gift card incentive, and they find much lower results there. And that could be for a couple of kind of mechanical reasons. One is the cash incentive program may have already persuaded those people that were persuadable. And even if there were still more persuadable people, you're moving from a higher baseline, right? Like you can only get vaccinated once. So the share of people that are remaining to be vaccinated, persuadable or not, is much lower after you've already done one of these programs.
So not as strong results as what you found, but also within West Virginia, probably not a fair comparison given the timing differences. So let's put this all together. I mean, this is an area that you do work in. We're thrilled to publish your paper, but this is not the only literature on the topic. If you're in the governor's office for the next round of some horrible pandemic like we're in, and they are confronted with having gotten to a point where they're worried that take-up of the vaccines is too low, what would you tell them?
Taken as a whole, all of these studies say that incentives matter. So doing something seems to help. And then there are some attributes that you want to think about when you're crafting your policy. So we think of like the desirable things about this. Receipt is certain, right? So we're comparing, say, a lottery to a cash incentive. And there were other programs too. One of my favorites was you could drive your car around the Talladega Raceway if you got vaccinated, right? So if this is a guaranteed thing. You show us your vaccination card and you can drive around the track. The second is that it's delivered immediately. It would be nice if it was even closer, but there was only a couple months lag before the program shut down. Those gift cards were going out in that time. Whereas the lottery incentives, you enter, and then we have this drawing at a later date, whereas the gift card can go out more rapidly. Another thing is the value to the recipient. And so we discussed this earlier when we were talking about the expected value, but also bleeding into those other incentive programs. Like, for instance, one state had one of the prizes was dinner with the governor. Potentially quite useful for some people, but maybe of little value for other people. And then the last thing that you need to think about, or perhaps the first thing, most important, is what it's going to cost per person vaccinated. So we want to think about the economic efficiency of these different things. So the lotteries may be quite efficient in dollars per person vaccinated. One study estimated it cost about $55 per extra person vaccinated. across all of the state lottery programs. Whereas ours, some of these people were going to get the vaccine anyway, so those $100 cash cards weren't marginal cash cards. So we haven't calculated this exactly, but it's going to be something quite a bit over $100. But that's not the end of the story, right? Because the goal isn't to get people vaccinated as cheaply as possible, but rather to increase your value. So if the value of a vaccinated person to your state is high enough, it may make sense to still pursue a more expensive but also more effective strategy, such as direct cash payments.
So I love the nuance in your answer, because I was sort of waiting for, well, you should do cash payments. And in fact, it is much more complicated than that. And I appreciate the levels of complexity, both in the trade-offs of who you reach and efficiency of the dollars you spend, but also in how you value this. The whole premise of the federal dollars going out is that we wanted people to get vaccinated, that there are benefits to that. And if there are benefits, then it's worth spending some money to make that happen. And probably different things will work for different people. And so having an evidence-based range of methods is a sensible approach. And it's nice now that we have a little more evidence to design those effectively. Well, Dr. Stoecker, thank you for doing this work. We, of course, hope we don't need it again soon, but it really is foundational in understanding a very unique situation where we all had to work on the basis of tremendous data limitations. And so having done this analysis, we really are much better informed for next time. And I appreciate your ability to explain it with such clarity and nuance. Thank you so much for being my guest today on Health Podyssey.
Thank you for having me. And I would be remiss if I did not thank my co-authors, Yin Wang, Julie Hernandez, and Kevin Callison. It's been a pleasure working with the three of you.
Thanks for listening. If you enjoyed today's episode, I hope you'll tell a friend about a Health Podyssey.